morning. I'm excited to be here today. Oops. There we go. So these are my disclosures. So our objectives this morning will be first to very briefly review the genetic basis for inflammatory bowel disease, which would be justification for genetic testing, and then to discuss several potential applications of genetic testing for our IBD patients, including genetic testing for diagnosis, prognosis, and pharmacogenetics. So what's the rationale for a contribution of genetics to inflammatory bowel disease? Well, it may seem like a foregone conclusion, but important to review. One of our earliest evidence is twin studies, not these twins, although it's a very funny movie, and I recommend it if you haven't seen it. But we're talking about monozygotic twins. The concordance in monozygotic twins for Crohn's disease has been reported to be between 35 and 58%. Whereas the concordance in ulcerative colitis is much lower and reports of 6 to 16% in twin studies. So what can we conclude from this? I had the distinct pleasure of working in medical school with Bruce Spitzan, so I was pleased to hear received the Janowitz Award this year. And he wrote a nice commentary in gastroenterology regarding counseling a twin in his clinic, that the epiphany is that even if one could describe every risk locus associated, contributing to Crohn's disease susceptibility, genetics would never predict the twin's likelihood of developing the disease better than the toss of a fair coin. So I think this should temper our expectations for genetic testing for the diagnosis or even clinically for risk assessment in IBD, but we'll talk more about it. Nonetheless, there's obviously been tremendous advances in our understanding of the genetics of inflammatory bowel disease. To date, over 200 genetic loci have been identified by Genome-wide association studies. We have to remember that Genome-wide association studies assess common variants, and they have relatively small effect sizes, each one with an odds ratio generally between 1.1 or 1 to 1.5. And 2/3 of these are shared between Crohn's disease and ulcerative colitis, again, perhaps tempering our expectations for the ability of genetic testings to distinguish ulcerative colitis from Crohn's disease. And together, they actually explain a fraction of the disease variants. So this diagram here shows risk loci across the chromosomes for Crohn's disease and ulcerative colitis with the connecting bars indicating shared variants. And for Crohn's disease, all the known risk variants only account for 13% of the variants in the disease. And for ulcerative colitis, it only accounts for 8.2% of the variants. Now, of course, strong evidence for a genetic contribution to inflammatory bowel disease lies in our very early onset patients, some of whom we identify a monogenic cause, a single gene mutation. And one of the landmark cases, obviously, is the finding of IL-10 receptor defects as a cause of very early onset IBD. So let's talk about genetic testing for the diagnosis of inflammatory bowel disease. Can we do better than Dr. House here? So what's available as genetic testing right now clinically? Well, there's a clinical panel available to us with genetic testing plus serology for the diagnosis of inflammatory bowel disease. And in this study led by Scott Plevy, they evaluated the addition of 4 genetic SNPs in addition to a few new serologic markers and inflammatory markers to a prior serologic panel. And the addition of these factors increased the area under the curve for the model from 0.8 to 0.87. But interestingly, genotype contributed least. So if you look at the chart on the right, you see this is a chart of the contributors to the prediction model and in rank order of their contribution to the model. And the genes assessed actually were at the very bottom of this list. So genetics contributed very little to the predictive value of this model. Well, and patients up to a few years ago, patients didn't even need us. They could take a swab from their cheek and send it into one of a few direct-to-consumer genetic testing companies where they would assess 200,000 SNPs across the genome and provide for the patients a report of their risk for Crohn's disease and various other common diseases and conditions. But what was a little disturbing about this, and in this study, they sent genetics to these companies on 5 separate patients to 2 companies. And frighteningly, 3 of the 5 patients for Crohn's disease, their risk was discordant what was assessed. And this was the case for other conditions as well. So this is the reason why the FDA removed the ability of these companies to provide this type of genetic information a couple years ago. So genetics at this, from what we've talked about now, genetics probably not so useful for diagnosing inflammatory bowel disease, at least common forms of inflammatory bowel disease, and also for predicting risk in a clinical setting. But what about genetics for identifying IBD phenotypes, so Crohn's disease versus ulcerative colitis, for instance? Well, this year, the International Genetics Consortium's published a genotype-phenotype analysis and include 35,000 patients. About 15% were under 17 years at diagnosis. And individual SNPs were not terribly helpful for distinguishing ulcerative colitis and Crohn's disease. But they did compute this Crohn's disease versus ulcerative colitis risk score, which compiled the risk information from risk loci across the genome. And they found that it had a modest predictive value with an area under the curve of 0.62. So if you look at the histogram on the right, you see this risk score across the x-axis. You see in blue colonic Crohn's disease in the hashed, and ileal Crohn's disease in green. And you see this separation across the risk score, but also you see this tremendous overlap. As a part of this study, they went back to the charts of these patients and re-examined a subset of patients to determine if after re-examination of the chart, any patients would be reclassified with regard to their disease phenotype. And they did find that those in the outlier scores, in those pink boxes, were more likely to be reclassified upon re-examination of the chart than those in the more median scores. But obviously, very few patients occur in those outlier scores. Well, let's move on to the topic of very early onset inflammatory bowel disease. This is a chart from an excellent paper by Uligs and colleagues from the Colors and IBD and Neopics groups, listing what was at the time the known single gene defects associated with very early onset inflammatory bowel disease and the ages at which they were diagnosed. So before we talk about what type of genetic testing we should do in these patients, I'd like to discuss what's the utility of genetic testing in these patients. Is it going to change management? And I think there is good justification for this, and we'll discuss it. So one is that hematopoietic stem cell transplant may be curative in some of these patients. So we know for defects such as the IL-10 signaling defects, XIAP, IPEX or FOXP3 deficiency, stem cell transplant is curative. Conversely, you may find a defect that indicates stem cell transplants contraindicated, especially for epithelial defects like an EpCAM or TTC7A. One reason I think is exciting is that the mutation identified may identify a pathway that can be targeted with a non-traditional treatment or biologic to treat the disease. So for instance, at Cincinnati, we have a number of patients with LRBA or CTLA-4 deficiency that have had some response to abatacept, the CTLA-4 fusion protein. We also have follow a patient with an activating mutation in STAT3 who has had response to tocilizumab, an anti-IL-6. And Scott Snapper presented yesterday some nice data regarding some nice results using anakinra in patients with IL-10 receptor defects to bridge them to transplants. And then, of course, genetic counseling is an important reason for all these patients. So what are our options for genetic testings in our very early onset IBD patients? Well, we have traditional Sanger sequencing, which will sequence a single gene at a time. And then we have next generation sequencing options available to us. And this includes a targeted gene panel. Panels include anywhere from 25 to 50 genes associated with very early onset IBD. And of course, whole exome sequencing, which will sequence all the exons of the coding region of the genome. Interestingly, only comprises 1% of the genome. and has the potential to identify novel variants. Important to know about all these modalities is that they'll generally miss mutations in non-coding regions and large deletions and duplications. So what's the yield of genetic testing in very early onset IBD? This is a nice retrospective study by Joachim Kammermeier at Great Ormond Street Hospital in London in Press Now. So they looked at 62 cases of infantile IBD over 20 years at their institution. And so this is infantile IBD. So all these patients, importantly, are under 2 years of age. And in 19 of 62, 31%, a monogenic cause was identified. 8 by Sanger sequencing, 37 by either whole exome sequencing plus or minus a targeted gene panel sequencing, and 17 just by targeted gene panel sequencing alone. The targeted panel they used comprised 40 genes. So when you look just at those evaluated by whole exome sequencing or targeted gene panel sequencing, a monogenic cause was identified in 18%. And interestingly, only 2 of 37, or 5%, that had whole exome sequencing had a potential novel causative mutation identified. That is a mutation that wasn't covered by the gene panel they were using. They also, in the patients where they had targeted gene panel sequencing and whole exome sequencing, they compared the sequencing coverage in these patients. And so this is a diagram of that data for 6 genes associated with very early onset IBD. It shows the exons for each of these genes, and the black or gray shaded region indicate an area where there's deficient sequencing coverage. And the take-home point is that when whole exome sequencing of known IBD genes, there was 14% of exons had deficient sequencing coverage, compared to only 1.3% in the targeted gene panel sequencing. So this is potentially one advantage of targeted gene panel sequencing in terms of the coverage of the sequencing. I provide here a list of what I could find as the known labs that provide targeted gene panel sequencing for very early onset IBD. They also provided some nice data on features associated with monogenic IBD. So what can we be looking for to identify patients with a higher likelihood of a single gene defect as the diagnosis? And so remember, they only looked at patients under 2 years of age, but in their cohort, only patients less than 6 months, as shown in this graph, had a monogenic cause identified, so symptoms beginning earlier than 6 months. On the table on the right, you see they identified a monogenic cause was much more likely if there was consanguinity, again, age less than 6 months, severe stunting, extensive disease, so pancolitis or extensive small bowel disease. Perianal disease was there was a signal, but not statistically significant. Interestingly, if there's an epithelial abnormality on pathology, and oftentimes this was increased apoptosis, a 90% chance of a monogenic cause in those patients. And then also they found if there was a TPN requirement, there was a higher chance of a monogenic cause identified. So how do we position genetic testing in the workup of very early onset IBD? This is, again, a very nice diagram from the Uhlig paper. I don't expect you to read it all, but they recommend starting on the left with a general histologic clinical radiographic evaluation. And then, if available, doing functional testing, predominantly immunologic testing, and potentially in parallel with your genetic testing. So if your functional testing is available at your institution in an expedient manner, and for instance, if you have a patient who presents very early on with, let's say, type 1 diabetes and dermatitis and extensive bowel disease, you identify by functional testing that there's low FOXP3 in the immune cells, then it might be reasonable to do traditional Sanger sequencing of FOXP3 for the diagnosis of IPEX. However, more and more of these patients we're seeing have overlapping features, and it's harder based on our clinical workup and immunologic workup to identify a target single gene for Sanger sequencing. And it takes a long time to do one gene after another serially. So potentially, for more and more of our patients, it's going to be more cost-effective arrive at a quicker diagnosis using either targeted gene panel sequencing or whole exome sequencing in parallel with our immunologic workup. So let's move on to genetic testing for the prognosis of inflammatory bowel disease. For those of you who don't know, this is Professor Sybil Trelawney of Hogwarts, the Harry Potter series. She's sort of the quack fortune teller of the story, so hopefully we can do better than her. So Marla Dubinsky published this seminal study that identified increased responsiveness to microbial antigen, increased immunogenicity as a risk factor for surgery in Crohn's disease in pediatrics. But they also looked at NOD2 status in this study, and interesting, while they found that NOD2 was highly associated with small bowel disease, there was not an independent signal of NOD2 for association with surgery, stricturing, or penetrating disease. Marla did a later study where they did a genome-wide analysis of over 1,000 Crohn's disease patients. 57% were under 16 at diagnosis. And here they developed a model that included 4 genes that did have some association with risk for surgery. So they divided the risk into tertiles, and the group 3 with the highest genetic risk had a 36% chance of surgery by 5 years, as shown in the Kaplan-Meier chart on the right, whereas group 1 had a 15% risk of surgery at 5 years. But while there was this association, the area under the curve for the model was still a modest 0.59. It's improved to 0.65 when clinical factors were added. And in that GWA meta-analysis from the International Consortium on Genotype-Phenotype that I discussed earlier, they also looked at the association between genetics and disease behavior in Crohn's disease. And while the raw NOD2 score was associated with surgery, when you do multivariate analysis, NOD2, again, highly associated with Crohn's disease location, but when you account for location, the risk for surgery from NOD2 drops out. So most of the surgical risk from NOD2 is because NOD2 is associated with small bowel disease. However, similar to what Marla showed, if you take a composite score that includes multiple risk loci across the genome, this score is independently associated with both Crohn's disease location and behavior. So the last section of the talk will be on pharmacogenetics. So we've all been using pharmacogenetics for quite some time by testing TPMT status prior to starting thiopurines. We're early adopters of pharmacogenetics. But what we haven't really had yet is as evidence that doing so changes outcomes definitively for our patients starting on thiopurines. And so now we have that data in adults at least. This is a randomized controlled study of almost 800 adults, randomized to standard treatment or pre-treatment genotyping for 3 common TPMT variants. And those with variants in the intervention group got reduced dosing, of course. The primary outcome in this study was a hematologic adverse event, defined as a white count less than 3 or platelets less than 100. 10% carried a variant. And in the patients who had a TPMT variant, in the intervention group, only 2.6% had a hematologic adverse event, compared to 22% in the control group. So definitive data here that doing TPMT testing improves the outcomes for patients with TPMT variants. But we're learning it's not all TPMT. So for leukopenia, in Korea, they acknowledged that the incidence of leukopenia was higher in Asians despite a lower frequency of TPMT risk variants. And in a large GWAS study, they identified a new variant in the gene called NUDT15 that was highly associated with thiopurine-induced leukopenia in Koreans with an odds ratio of 35.6. And this was, even though this variant is less common in European groups of European ancestry, it was independently replicated in those cohorts as well. Also, not just leukopenia, but for pancreatitis recently, a variant in the HLA region was found to double the risk of thiopurine-induced pancreatitis. Now, what about pharmacogenetics for anti-TNF response in pediatric IBD? Marla Dubinsky and colleagues did another GWAS study of 94 pediatric patients with both UC and Crohn's disease. They developed a multivariate model that included, again, 4 genes, as well as p-ANCA and diagnosis of UC versus Crohn's disease. That was highly sensitive and specific for primary response to anti-TNF, but these findings will need to be replicated in an independent cohort, but show some promise. So I'd like to conclude with the following take-home points. In my opinion, genetic testing is not recommended for the routine diagnosis of inflammatory bowel disease, to distinguish ulcerative colitis from Crohn's disease, or to ascertain risk for developing inflammatory bowel disease. But genetic testing should be performed in children with very early onset inflammatory bowel disease. Single gene sequencing, if clinical, immunologic, and pathologic evidence indicates a specific syndrome, or targeted gene panel sequencing or whole exome sequencing, may reveal a monogenic cause in about 20% of patients. Of course, TPMT genetic testing is recommended prior to starting thiopurine therapy, and future panels may include new genetic risk factors for thiopurine adverse events. And lastly, models incorporating genetic information across multiple risk loci may hold promise in the future for predicting risk for disease complication and/or response to therapy. Thank you very much.